Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Associate Professor Mal Itchens. I'm a medical oncologist and clinician researcher at Chris O'Brien Lifehouse and Royal North Shore Hospitals in Sydney. Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land in which we live and work. Today on the show, we're excited to have a multidisciplinary panel, which is essential for this topic, where we're overlooking the updates in lung cancer in 2025 in Australia. Today on the show, I'm excited to welcome two colleagues and friends, Professor Nick Pavlakis, a senior staff specialist in the Department of Medical Oncology at Royal North Shore Hospital, and Associate Professor Lauren Troy, a senior staff specialist in respiratory medicine at Royal Prince Alfred Sydney. Welcome, Lauren.
Thanks, Mal. Good to be here.
So I'd like to welcome you both formally to TOGA's Conversations in Lung Cancer Research podcast. So importantly, in the podcast today, we're going to cover two really important aspects of the care of lung cancer in Australia in 2025. One of them being, of course, the introduction of lung cancer screening in Australia. And Lauren, you'll take us through your expertise in the area. And then we'll talk about the new expected PBS drug listing coming in 2026 and how that's going to influence our practice in lung cancer. To start us off, I think the big ticket item for lung cancer care, certainly in Australia, has been the initiation of lung cancer screening for those high-risk individuals around the country. And our screening program, which was long awaited, went live on the 1st of July. Just to reiterate, this includes those aged 50 to 70 whom have had a 30-pack year smoking history and are current or former smokers having quit within 10 years with no concerning lung cancer symptoms. And the Australian program is a little different in that it incorporates a biennial or CT every 2 years, a low-dose CT, obviously more frequently if there are abnormalities found on the screening CT. So Associate Professor Lauren Troy is an expert interventional pulmonologist in Sydney. And I guess, Lauren, so my first question to you is, in the months since the screening program has kicked off, what's been the impact on the diagnostic services and your respiratory clinics thus far?
Yeah, firstly, I'd just like to say I think that the screening program is a very positive thing. It is obviously designed to capture lung cancers at a much earlier stage. What we are experiencing now is really a period of transition. We know that a lot of lung cancers are presenting very late, and the traditional patient that we would be working towards diagnosis is often very advanced in their malignancy. And at the moment, at the infancy of this program, we're still seeing a strong bias towards advanced stage cancers, but starting to see, as these screening patients come through our clinics, these much earlier, very early curable cancers that we are able to triage over to management at a stage where you can actually see benefit. So I think that it's very early days. We haven't yet seen the true impact of this program, but starting to see that shift in the flavour of the referrals that are coming through our clinics. And I would say that we have already, as a nation, done a really tremendous job in pushing through over 37,000 screening referrals, even in a very short period of time, which has picked up, I'm told, 426 high-risk and very high-risk nodules. So those 426 people have come to clinics like ours and presumably gone on to have more comprehensive evaluation of their nodule. And the question you asked about how that has impacted our diagnostic services, again, I think we're still in the early days to know what that true scale of impact is likely to be, and particularly in centres where the resources may be a little stretched, such as regional settings, the ability to meet resource needs for this screening is still under a lot of investigation, and that we're still going to find that we don't always have a diagnostic service that's going to be able to capture all of the patients in that timely fashion. But hopefully, with a bit of time, we'll be able to match resourcing appropriately so that patients with lung cancer can get their diagnosis within that optimal care pathway timeframe.
Those numbers are impressive. I agree. And so tell me, just to push you a little bit further, for those you've seen coming through the screening program through your service, what kind of wait are they seeing before they can get a biopsy with yourself? And what's been the experience at RPA for those that may go down an interventional radiology pathway?
Yeah, most people with high risk, very high risk nodules will need a biopsy, and those procedures are traditionally occurring in interventional radiology or in the bronchoscopy suite. When a patient has a later stage or a suspected later stage malignancy where you can sample lymph nodes in the mediastinum and the hilar regions, it's very clear cut, and EBUS is the path forward. But that's not what we're talking about with lung cancer screening. We're talking about the isolated nodules that are often quite far out in the lung periphery. So we are traditionally, as I said, going towards interventional radiology. And if we look at the wait times here at our centre, people can usually get their diagnostic percutaneous biopsy within the 2-week period. But when it comes to bronchoscopic diagnostics, we still yet to, I think, really expand the diagnostic services to be able to keep them within that 2-week period. We're very fortunate to have expanded our advanced imaging guided bronchoscopy service here at RPA. And so in the new year, we'll be able to hopefully be able to accommodate these peripheral nodule diagnostics in a short period of time within that 2-week period. I think that the balance of demand and availability is still not clear to us as we still see the program in its early stages.
So to take it further, what do screening programs tell us about uptake and who most benefits from lung cancer screening?
So obviously we have only got a few months of data in our own context to know where the benefit truly lies, but some emerging data from more established, mature screening programs in international settings have started to give us a sense of the benefits in terms of survival and stage shifting. And so one study based out of Yorkshire has shown that people who went and had their lung cancer diagnosed at an early stage and then went on to receive either a surgical resection or SBRT for curative intent, that the bias towards sending frail people who are older towards SBRT did see a significant increased mortality signal in that group. They were not dying of their lung cancers, they were dying of other frailty-related conditions that had prevented them from having surgical cure. So I think that the message there is that in older people with an array of comorbidities, that the value in capturing lung cancer earlier is not necessarily for a survival benefit. And so we should be thinking carefully about who we want to screen for the purposes of early lung cancer detection and expected benefit. And so that data, I think, is something we should pay attention to. And then I guess the other thing to say is that we have started to see a lot more uptake in the American setting where a lot of the programs have become a lot more established. The uptake has been quite slow, so somewhere between 2 and 3% in some jurisdictions of eligible people actually going and having screening was some of the disappointing early data. But we've seen a shift now towards a higher uptake across the board. And so in 2024, there have been some data to say that as many as 1 in 5 eligible people are getting those scans now, the low-dose CT scans, and with quite a large expected survival benefit in those patients that at a national level. So I think the message there is just we need to understand that there will be a time required before the education of the referrers and the general public sees the numbers that we're hoping to achieve in terms of screening program targets and the goals being met. But at the same time, we also need to be able to meet the needs of the diagnosis of these nodules by having sufficient services to be able to move patients with high-risk nodules in an efficient timeframe. And then again, I'm sure you'll agree here, but we need to have sufficient management structure so that patients who have a confirmed cancer can have timely access to curative and comprehensive and cutting-edge therapies such as the ones that you're prescribing.
I agree. And I think the role of specialist nurses in that arena is really important to move people through what is a very complex system, as we know, particularly tertiary care, in a very efficient manner. And so you've spoken a little bit about those at risk. And I think our screening program has started with quite a tight, high risk criteria. I'll ask you a question, then bring Nick in around where you see the future expanding for the criteria of those whom could further benefit from screening. And whilst you're answering, I know that Nick has an interest, particularly in looking at liquid biomarkers for the screening program. So where are we going next to the next populations of need?
I guess I won't answer out of my own area of expertise, and happy to defer to Nick on the subject of those circulating biomarkers for screening purposes. But I think that one obvious expansion will be what's happened in other international screening programs where we do expand the age group to capture a bigger at-risk group, and the increase in age in some screening programs is even as high as 80 years, has obviously seen a lot more people become eligible. But here it comes back to the question of net benefit in terms of quality life years and healthcare costs and survival. And we have to understand that net benefit becomes diminishingly small in multi-morbid people who are becoming increasingly frail and older. So I think it's going to be difficult to use age criteria alone to capture the best people, because as we know, some 80-year-olds are ready to climb mountains and are very robust, but others are not. And similarly, some 60-year-olds are very frail. So age is, I think there is a limit to the smoking factor and the age factor to be able to get the broader population that we see. And it doesn't even come close to addressing the non-smokers, the never smokers that we are increasingly seeing as well. Yeah, over to you, Nick, for where the future lies.
I don't know where the future lies, Lauren, but I will say a couple of things. At North Shore, we practice in a slightly different demographic. We have one of the lowest smoking rates in the country. We do see quite a lot of Asian immigrants with family histories. I've got quite a few that actually have 2 generations of cancers and lung cancer. And I guess based on the Taiwanese study, one area as our population changes is the non-smoking related area. But I guess we've got to first see the value of the screening program in the general population before we can argue to government to expand it. And we need to make sure that we expand it in the right way, because it's going to have to be cost effective. The other point I think Mal raised earlier was around blood assays, other diagnostic tests. So this is more from a research perspective, Mal, as we've been discussing and Lauren, you'll have seen these, that you'll have the definitely suspicious of cancer. You have the nodules that we're really not worried about. And then you have the in-betweeners who go down pathways of quite frequent scanning. And it's how to increase the sensitivity and the diagnostic accuracy in that group without putting them on a perpetual program of multiple scanning. So involving multi-omics, including ctDNA and other blood-based assays, and algorithms using AI on imaging. So these are just research concepts. I think there's a group through the Tracker program that's interested in that. We've proposed a concept through TOGA. We're just trying to find appropriate vendor supporters to assist us. And we might be able to look at integrating that from a research question point of view into that population of suspicious, but all we can do is repeat the scanning population and see if we can improve the diagnostic algorithm of testing with these extra tools.
There's another reason to reconsider CT scanning, although I think we're a long way from that. But the capture of all these other pathologies in this very vital space that sits between the root of the neck and the diaphragms, I think that we have to take on with this current scanning a whole lot of resourcing to deal with all the incidental findings, all the reportable ones. And not to say that we don't want to know these things are there, but a lot of those things are not necessarily things that would require further treatment or evaluation. They just cause a lot of anxiety. So there is some challenge, I think, with the low-dose CT scan as the crux of this program. But I think we'll obviously refine the way that we're using that data and that information, and hopefully with the benefit of AI, there might be something in that to even deal with all those incidentals as well.
And before we move on, a brief question to you both. Are you aware of any international studies that are recruiting in a non-Asian population, non-smokers with other risk factors? Because that's the data we really need to see coming through for our Australian context and expansion of the criteria. I just can't see us having a lung cancer screening program that has a criteria only pertaining to an Asian population, but I may be wrong.
I'm not aware of focused screening in those other at-risk groups, but I'm sure that's a study that we could even look at here. In a nested study in Australia, it would be such a fascinating subject to address, but difficult.
And so I guess your area of expertise, as you've alluded to, is the tricky to biopsy nodules and how we get in. And I think Nick and I, as Nick has mentioned, we often sit in MDTs where there are multiple bilateral ground glass opacifications, where we talk about staged biopsies, we talk about prioritising which lesion looks a bit nastier and thinking about the others later. Could you take us through in brief where the technology is going in Australia to assist us with our diagnostic precision, particularly in a screening population?
Yeah, I think we're in a really exciting era and when it comes to nodule diagnostics and in the era of interventional bronchoscopy as well. Of course, that's my bias, but what this actually represents to people is an opportunity to have an all-in-one diagnostic and staging procedure. You could potentially go after all of those nodules if there's clinical need for that all-in-one. And so the notion of a bronchoscopic diagnostic procedure it carries a lot more benefit for the individual than the simple percutaneous biopsy, which would be then followed potentially by further investigations. We are now able to speak confidently to what interventional bronchoscopists have known for a long time based on a publication early this year, the Veritas study in the New England Journal of Medicine. This compared in a randomized fashion people with peripheral nodules who went on to one of two diagnostic pathways, percutaneous biopsy under radiologic guidance or bronchoscopic biopsy using an advanced navigational system. And these data, the study was designed for non-inferiority of the bronchoscopic approach, but what it actually showed was a very significant difference in adverse events. So people who had the percutaneous biopsies had something in the order of 25 to 30% pneumothorax rate, and the bleeding risk was also substantially higher, with a diagnostic yield of approximately 73% and a very similar, in fact, slightly better diagnostic yield in the navigational bronchoscopy arm, but a substantially lower complication risk. And then subsequent to that publication, there have been meta-analyses and a clinical guideline published by the American Association of Oncology and Interventional Pulmonology and JTO that shows that difference is borne out in an evidence base, so that the non-inferiority of diagnostic sampling between bronchoscopic approaches and percutaneous approaches is borne out by the evidence, but that very substantial benefit for avoiding adverse events is the most compelling thing. But as I said, there's more than just that. It's also the fact that you could get not only your peripheral nodule diagnosed, but your mediastinum staged within one procedure, one anesthetic. And there are also, I guess, some other things that are maybe a little bit smaller in terms of their risk for the individual, but not irrelevant. And some things like tumor tract seeding and pleural seeding in a needle biopsy is, I think, something we need to be really mindful of. Increasingly, we are starting to see early stage malignancies with evidence of early recurrence in pleural spaces and other. So I think we need to be really aware of these risks when we're choosing a diagnostic pathway. And so the technology now, which not only includes advanced navigational software, but also advanced imaging guidance using cone beam CT and really excitingly robots, we can start to see this infiltrate the Australian landscape. And while still only in a fairly narrow array of hospitals, very well-resourced hospitals, usually at least one per state, these advanced bronchoscopic approaches are starting to make their way into other settings settings around the country. And again, it comes down to resources and advocacy, and someone in an executive position agreeing to approve your access to the hybrid theatre or agreeing to purchase the advanced technology. But what we're starting to really see, I think, it's going to be a very complementary approach to the lung cancer screening program. And this is what we've seen in the US, where interventional pulmonology has really become a very big area of growth. And that's because of all of the advantages and the safety that we can see translate directly into hospital cost avoidance and hospital revenue. So, yeah, we're pretty excited about this. Robots are starting to appear in bronchoscopic suites. They're everywhere across the states, and they're also in many European and Asian settings. It'd be great if the Australian healthcare setting could support that in a more robust way. But we're all trying to make sure that first we can get those cancer diagnostics done in a comprehensive, timely fashion. And we want to make sure that our healthcare setting is able to cover a broad array of pathways, but not leaving people in regional or remote settings out in the cold because of limited access to those things.
Yeah, I completely agree. I think that's an excellent place to start wrapping up our discussion around the screening program. But being a medical oncologist, I would be remiss not to mention drugs. And I guess to Nick, so we're expecting, as the UK have experienced stage migration, more stage 1 non-small cell lung cancers coming through screening. I guess we're starting to see increasing feasibilities for clinical trials around those stage 1s that maybe are high risk stage 1 for recurrence. These are patients we don't usually give further systemic adjuvant therapy to. Do you feel there'll be a place for systemic therapy in the future for stage 1 lung cancers? And are there any areas that particularly interest you in that arena?
Yeah, if you go back historically, Mal, histologic adverse prognostic factors have always existed for stage 1 lung cancers. Solid micropapillary and other subtypes have always done poorly, but there haven't been specific studies to address those. And if you look at the survival rate of stage 1 lung cancer in Caucasian populations, it isn't comparable to stage 1 breast and other tumor types. Only the Japanese can hold their head up high with the figures for early stage lung cancer. Biologically, I think there would be, but you need to have proper data to identify it, and then obviously cost-effective data. It's interesting with the staging, because I would have expected, I'm curious to see, while we're still talking staging with Lauren, that the first group of patients you'll see are the prevalent cases that would have otherwise presented in the next 6 to 12 months. But it doesn't sound like it's fallen that way. Is that correct, Lauren? Or that you might have higher stage, so 2B, 3, rather than ones at this stage, and the ones will come as the program's expanded out more?
I suspect that's the 37,500 odd cases with 426 patients that have been referred to clinics has been spread pretty broadly around Australia. So each clinic is probably not able to say what the trends look like. The biggest burden of referrals to our nodule clinics remain the incidentals that have been picked up through CTCAs or other pan scanning for other indications. So it's very difficult to tease out the sort of staging topography because of that huge bias in that early stage referrals through incidental screening, like not screening, but scanning. So yeah, I suspect that we will see some of those more prevalent cases than we have initially seen, but it's a bit of a critical mass is needed before we can see those trends.
Mel, back to your point about this early stage disease, we know that MRD in resected lung cancer is a really strong prognostic factor. It's yet to be validated as a predictor as you're doing studies to address that with the DOPT lung and others. So I guess integrating that sort of information in a resected case may identify which patients should be given additional therapies and who don't need it.
Yeah, I completely agree. I was pushing you a little on the MRD space, as I think you and I both are quite interested in that population. So in the interest of time, Lauren, thank you so much for taking us through your screening experience to date. We're going to move now on to some therapeutics, and please feel free to also chime in as you see fit. So I guess moving now on to Nick, what we were going to do is talk about some of the positive PBAC recommendations for therapeutics in lung cancer, just touch on the data, and then I'll ask Nick for your input just around what that means for your practice and the practice for our lung cancers in Australia. So one of the listings we've seen in 2025 was for dabrafenib and trametinib in BRAF V600E mutant non-small cell lung cancers. What I find interesting about these data is we actually saw the positive phase 2 data in 2017. We're now sitting at 2025, but better late than never. These are drugs that have been used in the melanoma setting for some time. And we've seen overall survival data for BRAF mutant lung cancers, 22% at 5 years, using these drugs up front. A modest but real progression-free survival, 10.2 months. For pre-treated, 10.8 months for treatment naive. So this is now a standard of care for us in Australia. I think the side effects we can touch on in brief. But Nick, so you see a new BRAF V600E mutant lung cancer come through the clinic, had a bit of a smoking history. You're treating them up front now with these drugs. What are your considerations around the care for this rare population?
I had to give a talk on this only just the other day, Mel. So I had to look at the whole data set. So prior to the availability of these drugs, we'd give chemoimmunotherapy. And there are some patients that can have high PD-L1 proportions with them. But the benefit, just comparing indirect population sets with the chemoimmunotherapy approach, doesn't seem to be as substantial or for as long. So the DAB-TRAM, we'll call that for simplicity, had a good response rate both first and second line setting. They are older generation trials, and there was an efficacy also in the CNS. And I've had experience with the use of it in limited situations. I've only just put my first patient on a PBS version the other day, a lady who actually had chemoimmunotherapy and had a disease-free interval of around 6 months, which is not very long, obviously. And so she's just about to go on. So I'll probably answer your question of my success from that. I've also used encorafenib and encobini within the setting of a clinical trial. And just from a proof of concept point of view, I've had very good long-term results in a couple of patients with that. So we'll have to get familiar. Those who treat melanoma will be familiar with the DAB-TRAM and the fevers that can occur. There's a well-established protocol on EviQ about management of fevers, and dose interruption being the key, and in refractory cases using steroids. That's for the DAB-TRAM combination. Rarely is dose reduction required. And I think with careful monitoring, it can be managed. So it's good to have the option. And I would say BRAF behaves like other oncogene-driven cancers. And I would want to use an oncogene suppressive therapy up front and then use chemoimmunotherapy as in the refractory situation.
Yeah, that makes sense. And obviously we know our patients like tablets. And once we start driving these drugs, I agree. I've got someone who's having some of those symptoms you suggest now and just learning how to manage it. And I guess you've mentioned encobini, and my understanding is it's also up for review for PBAC this month. So we may go from a famine to a feast for BRAF, which is excellent. So moving on to one of our favourite topics, which is ALK-positive lung cancers. We are pleased to see also a positive PBAC recommendation for alectinib as per the ALINA trial. This audience will be aware of ALINA, randomized phase 3 in resectable ALK-positive lung cancers. Cancers need to be, in general, 4 centimetres or above. And what we saw is with 2 years of alectinib versus standard of care chemotherapy, very significant disease-free survival, hazard ratio 0.24, disease-free survival not yet mature in alectinib. We saw updated overall survival data at ESMO 2025, and actually at 4 years, 99% on alectinib are still alive. So it will take a long time to see overall survival in this population. So Nick, game changer, and how do you feel around the data and what it might do for our also access to ALK inhibitors for those with early stage?
I think the study stands alone. It's obviously adds to the volume of data for early oncogene-driven cancers, but it is different to the DORA study in EGFR because this one actually randomized compared to chemotherapy rather than in addition to. We put 2 patients on this study. It was hard to accrue because you don't see many ALK in the early stage disease. My main concern, I want to see the long-term data. What we've seen so far is 2 years seems to keep the disease-free proportion still very good, but we haven't seen what happens at relapse. And as we know, many of us have got ALK patients with metastatic disease up to 10 years. And my understanding is that we don't have the option of reintroducing ALK inhibitors at relapse in the way that this has been approved. So that would be my main concern. I guess when you're going for cure, you think we're not going to wait for a relapse. We're going to go give our best therapy up front, but we want to see a bit more long-term data. So I'm grateful that it's actually been given the nod. And probably when given a choice to patients, I'd say that they probably would prefer to take it. But that's my reservation is understanding that there is a proportion that might relapse, and being able to have the option of reintroducing our targeted therapy at that situation, I'd really want to have that option.
I agree. And I think it's important for us to think about as a lung cancer community advocating for that, as the data also with Adora and osimertinib, really you do see a re-response as we'd expect based on the nature of TKIs if we've suppressed recurrence and delayed recurrence. And the CNS protection, I think, is really important in the adjuvant circumstance. Brain relapses are unfortunately not uncommon in this population. And so that to me also is really important.
It's not logical to not allow a drug to be used in relapse when you look at other precedent situations such as GIST, where Gleevec was given for 3 years and it was made available on relapse. And especially in ALK, where you actually have more drugs available. So we have lorlatinib available on relapse. We know that's shown efficacy in the second-line setting, very powerful in metastatic disease. So I'd hope that over time, with right advocacy and long-term data, that the decision to allow our targeted therapy on recurrence would be open.
And so this shifting gears, EGFR lung cancer has seen a lot of airtime in the recent years. So we're expecting in early 2026 listings for both the LAURA and FLAURA2 protocol. So LAURA looking at osimertinib indefinitely in a locally advanced EGFR positive population. Just to recap, it was a randomized phase 3 study, LAURA, that looked at chemoradiation in an inoperable locally advanced population. And really that was a very positive study given how poorly also the control arm did. So those who received chemoradiation had a progression-free survival of 5.6 months for a curative intent treatment. That's debatable, versus 39 months with osimertinib, hazard ratio 0.16. So I guess for us, that has been practice changing. Progression-free survival in the brain, hazard ratio 0.17, and pneumonitis that looked also quite manageable. So only 2% receiving Aussie post-chemo rads had grade 3 pneumonitis. So Nick, in your practice, are you seeing a lot of locally advanced EGFRs, and anything to add on that practice-changing data?
I think it's a compelling study. I guess there's some questions around it, that the performance of the control arm, but it is what it is, and you've got to look at the internal control of the study. We've always thought that the EGFR population should be treated differently to the combined chemo and durvalumab situation. So this validates those thoughts, and I think this should be the standard of care. But we don't see many stage 3 EGFR positive cancers. And I would say that the stage 3 population, outside of what we might be seeing with screening, generally, certainly in North Shore, has been diminishing in our hospital. When and if we see a patient, I'd like to treat them in this fashion, and I think that data supports it.
And then moving to the advanced circumstance, osimertinib has treated us very well for a long time. We've now seen 2 overall survival positive phase 3 trials with a significant overall survival benefit in FLAURA2 with chemo and Aussie, hazard ratio around 0.7, and similar for Mariposa, amivantamab, and lazertinib. FLAURA2, we understand we should see a listing in early 2026, and Mariposa at the moment is waiting on a mature overall survival readout. So for an EGFR positive cancer, who are you giving more than osimertinib to?
This is a hard thing because when I looked at the data and it was presented in the forum, my immediate reaction was, I know for a fact I'm not going to be able to give chemo or osimertinib to everybody. There will be subpopulations that A, just will refuse, B, have such limited disease that it's hard to justify it. When you see a population study, what it's telling you is more people will benefit longer by combining chemotherapy with osimertinib. But for the individual patient in front of you, is that the best treatment for them? And I think we need more information on that, perhaps with molecular profiling, ctDNA clearance, things like that. So there'll be a horses for courses situation. Mariposa has presented some of its molecular data. It's a more toxic regimen. I think if you had the option of both of those, I'd go chemo and osimertinib. But what I'm trying to say is that there are people who will benefit from osimertinib alone. And we've shared those patients. We've had them together over the years who then can be offered chemo, or even the Mariposa 2 concept of giving chemo with amivantamab at relapse if it is required later. And there was a Chinese study presented at World Lung, I forgot the name actually, where they actually looked at upfront ctDNA positive patients and added chemotherapy. I think you might recall that study. And it showed a benefit in favor of adding the chemotherapy in that selected population rather than empirically on everybody. So I think we need, the more we understand what I've learned about EGFR and oncogene cancers is we don't know what we don't know. The more we delve into the biology, the more nuanced it becomes. And I think, and I would say that probably a lot of people who treat a lot of lung cancers similarly would say that they wouldn't treat everyone the same way. But yes, if someone's well enough, we have to present it to the patients and tell them about that option. Some people will make a preference not to do it. And there will be some people who, because of comorbidity, they're not well enough for it. Yeah, I think it'll come into practice, but I don't think it'll be for everybody.
I agree. And I couldn't agree more that I look forward to when we give induction therapy and look at biomarkers, the obviously one being liquid biopsy and clearance, to escalate therapy and then even perhaps de-escalate therapy. I guess what we saw from FLORA-2 at World Lung was the intensity of chemotherapy wasn't indefinite. So it was 8 months, the median for pemetrexed. And I think that's been comforting to some of the patients I'm looking after in FLORA-2 to know that we could phase out the maintenance chemo.
Yeah, absolutely. I guess it didn't properly address the question of can you give less. It just said that you don't have to go forever. In real practice, I'd like to know whether I could just give 4 cycles or 6 cycles and then stop, and whether that big impact up front is enough to actually influence the outcomes. But that's the sort of academic question that maybe when these drugs are approved, we can actually put a study together and answer, Mel.
Yeah, I agree. Now, because we have so many drugs in lung cancer, because that's what we do these days, I'm going to move us along to ROS1 and repotrectinib, a drug we've known about for some time in the Trident studies. So again, Repo is looking to be listed early 2026. And that phase 1-2 data, I understand we're not needing to wait for phase 3 for regulatory bodies in ROS1, which is music to our ears. We see objective response rates 89%, so up there with other fusion data. PFS 36 months as per ALK. So really, this data are exciting. What I would also say is repotrectinib can be utilised with success after crizotinib or entrectinib, our standard of care, active in the G1203R gatekeeper mutations. So this is exciting. Repotrectinib, would you use it frontline in everyone? And how do you feel about the TREC toxicity that can come along with these drugs?
Well, I haven't actually personally used it. I'll say that up front, Mal. I see the availability of repotrectinib a bit like the ALK story. The more drugs in the toolbox, the better. I think it's a second-generation drug. It's got CNS activity. It'll probably push crizotinib a little bit out of the way. And for those who are on crizotinib doing well, it certainly is good to have another option available to us. So I can't comment on the specific toxicity as I've not experienced the drug as yet. But I think this is giving hope to the ROS1 patients akin to the ALK patients. We've got a number of drugs available. I think the ROS1 relapse story is similar, but not the same as the ALK story in terms of kinase domain, alternate pathways. So the more drugs we have and the opportunity to switch is great for the patient.
Agree. I'd just make a brief comment to a 4th generation ROS1 inhibitor coming through, I think pronounced zidesamtinib, the new valent drug. I've had a little experience with that, and I would say that is one that doesn't seem to have some of those TREC side effects, such as dizziness, dysgeusia, paresthesia, and some of those withdrawal symptoms. And so I wonder if we're going to see that one also forge through as a really strong frontline ROS inhibitor in the future. So again, whilst we have you, we have Adriatic durvalumab for limited stage small cell lung cancer, presented at ASCO last year, positive phase 3, chemo rads for limited stage and a year of durvalumab after, extremely positive. So for overall survival, which looked at a benefit going out to from 34 months to 56 months, pretty substantial. So this is also exciting data for the limited stages we find. Again, anything to add around this? It looked tolerable. It looked manageable.
Yeah, look, that's a great study. It's another diminishing population. And in small cell, limited stage small cell, we don't see that many. I believe the staging data that I've read so far, and perhaps correct me if I'm wrong, Lauren, doesn't show much in the way of change in patterns of presentation of small cell, but we haven't tested it in our population. When we do get a limited stage small cell, this is now a new standard of care. And I said, but I haven't seen that many in the limited stage yet to be able to adopt this. I think probably a handful per annum at most.
Yeah, and they come in waves, don't they? None, and then you see 2. And the question I have to ask is the one that remains controversial. So it was dealer's choice PCI in this population. It was about 50-50. In your practice and our practice, do we recommend prophylactic cranial irradiation in these patients now that could be realistically living years?
I think we've all adopted a watch and see, careful surveillance approach just to try to prevent neurocognitive effects. In our department, we've had that philosophy for some time. In the advanced stage, extensive stage small cell population, where there was still also a role for radiotherapy, we've not used that anymore. And so we've tended to reserve it for really the type of progression that warrants it. And delayed whole brain radiotherapy is, I think, the general practice in many places.
Yeah, I agree. I think when you see some of that chronic toxicity, which is a good problem to have in small cell from whole brain, you really don't forget it. Finally, the listing that has been last but not least is looking at a more broad listing for ipilimumab and nivolumab for immunotherapy. And I guess that's exciting. And so for you in your practice, Nick, where do you see that the reutilisation of immunotherapy may have the greatest impact for our lung cancer patients, given we've had this once-in-a-lifetime mandate?
Yeah, look, there's a number of open questions in the immunotherapy, in the use of checkpoint inhibitors in immunotherapy in lung cancer. Can you stop early in some patients? Should you continue beyond 2 years in others? And what's the optimal therapy at relapse? I don't think we've got any study that's formally addressed that. What this indication has done is it's given us the option to be able to reintroduce chemotherapy in the form of dual checkpoint inhibition. Whether that's the right treatment or not, I'd say we could probably do that in an observational study in the Australian context and collect some data. I think that would be good. It probably gives us the flexibility to do some of those changes that we said, because in the past we wouldn't want to stop immunotherapy early because we couldn't reintroduce it. But there are some patients, as you know, that are very well connected to finish the 2 years and then are frightened to stop. I'm not sure that I'd necessarily switch them directly to ipi-nivo, but I'll be able to say to them, we now have an option there. I think it's important that we try to get data to try to validate which approach is best. But having the drugs available is the first step to being able to conduct the type of studies that address these questions of duration of therapy, reintroduction, etc. So now that it'll be available, that's something that we can address. We've talked about it a lot in the toga space over the last few years.
And Lauren, did you have anything to add there?
I just curious, as a respiratory physician with a separate interest in interstitial lung disease and not infrequent referrals for drug-related pneumonitis, I wondered just what the general tolerance of the ipi-nivo combo is in your experience as a prescriber. And it sounds like a really exciting frontier now that some of these restrictions are no longer going to be limiting therapy. But do you see that having an impact on my clinics? But beyond that, is this something that is worrying in terms of side effect burden, or is it generally pretty well tolerated?
It is, if you depends on what your dose of ipilimumab is. So most of our experience has been with ipi-nivo in the mesothelioma space, which uses the low-dose ipi protocol. Because if you use high-dose ipi, you have a much higher proportion of grade 3 events. So I think if we stick to a low-dose protocol, carefully select our patients, we shouldn't change our behaviours just because we have this option. We still got to choose the treatment in the right patient, avoid the treatment in the wrong patient, and still follow those same principles that have served us well. And I think the risk is that, yes, it'll be overused and it may introduce some toxicity in people who otherwise would not have encountered it. So we'll just have to watch and see. I think that is the kind of thing that individual departments have to monitor in terms of audit of their practices and see. I'd hate for that to happen to patients, but I'm not going to change my selection of patients. Not going to change my which patients I would avoid doing immunotherapy, and I'll still have the same discussions. We'll bring them to our MDTs, discuss with our thoracic colleagues, and say, look, if this person got even a grade 1 event, it would be too risky. We're not going to give them therapy. Ipi-nivo, low dose, great. A high dose, I'd worry about.
Well, that's really interesting. I didn't realize there were dosing strategies. So it sounds like the way to go. Yeah, it's a really, I think, interesting era in respiratory medicine, the fact that we are seeing so many different oncological challenges, not just in the screening and diagnostics, but in the therapeutic side effect profile. But it sounds like you've got it in hand.
Well, hopefully.
What we don't have in hand is the drug resistance space, which I haven't given airtime to. But obviously, we increasingly need you with these complex therapeutics to help us understand if it's true drug progression or if what we're seeing is a manifestation of a toxicity, of course.
Sounds like space for biomarkers.
Yeah, absolutely. So I guess in the final couple of minutes of this podcast, it's a question to Nick, but then to you, Lauren, as well. Let's take it from drugs as well as to the diagnostic space. In 2026, to each of you, what do you think is the next most exciting thing coming for lung cancer? And that for you, Nick, can be drugs or technology.
I think two things. One is new agents in the form of tarlatamab next year, and probably we'll get amivantamab approved with chemotherapy in the Mariposa 2 trial. So that'll give us a few options there. In the broader sense, it's the data that's building on the integration of biomarkers such as circulating tumor DNA and or MRD. I don't think we're going to have definitive data next year, but the more that emerges, the more it's going to, I think, hopefully help to guide our practice depending on the quality of the data. So I'd like to see more of that as we're doing studies, but many aren't going to read out next year, but some of the studies, some of the biomarker studies of other presented phase 3 trials will be read out. So we'll have some info.
Yeah. And before going to you, Lauren, I guess our other oncogene of need is the HER2 mutants. We hope we see a listing for trastuzumab deruxtecan HER2, as well as increasing access to small molecule HER2 TKIs like zongertinib. And I think it's a podcast in its own right, isn't it, for the KRAS space, and many of the new generation KRAS inhibitors thankfully coming into the clinic, moving beyond as well, KRAS G12C. So Lauren, what about you? What's your hot pick for lung cancer 2026?
I'm going to say two things. And one, I think, is the rise of the lung cancer nurse, and particularly in the case management of people going through the screening program. I think that the increased focus on lung cancer has seen an injection of funds. I wish there was a more homogeneous spread of the funds with the diversion of some of the McGrath nurses into lung cancer space. Some state-based government funding has also seen injection of resourcing. So I really think that there's much more personalised navigation from a diagnostic path right at the beginning of the journey, as opposed to after the bit where you've got the diagnosis. I think that's a very exciting development. And the other thing, which it would be remiss of me not to mention, but it's really the rise of the robots and also the more advanced technology in diagnostic space, where we are heading perhaps maybe crystal ball gazing, but as a field, we're looking maybe at a day where we might be able to not only diagnose, but also treat the tumour in the airway with increasingly sophisticated ablative technology and other new novel therapies. That's a long way off, but to get to that point, we have to really ensure that Australian healthcare setting is resourced with the most precision diagnostic tools that are also the safest for the patients.
Yeah, that's exciting. I think the toga debate for the ASM next year, the rise of the robot.
There you go.
So my final point will be around the MSAC review currently underway for liquid biopsy, as Nick has alluded to. And I think anyone that sits in a lung cancer clinic knows how important it is to get a timely diagnosis, and that tissue is the issue. And in that patient population in particular, we hope we see liquid biopsy being available in 2026.
Absolutely, Mal. Hopefully that'll be reviewed in a positive way next year.
So that brings us to the end of a long and very fruitful discussion. And I love the multidisciplinary nature of today, even though we broke it up into 2 chapters. So thank you, obviously, both Nick and Lauren, for joining us.
Thank you. Thanks for having us.
And thank you always, our listeners with Toga. And thanks for tuning in to Toga's Conversations in Lung Cancer 2025.